So students, today in our pediatric neurology series, we will be talking about cerebellar test in children. So this is a very interesting area because often we have some problems in the cerebellar function. We suspect some problem and we have to test the cerebellum as a part of nervous system examination also. But due to varying ages of the children, because of varying maturity, the skill of cerebellar testing is very different than in adults. So as in adults, we expect that the subject is sitting very comfortably and cooperating with us with full attention to us, although there may be exceptions. And this is not true in small children. The children are often found in mother's lap, or they are playing on the bed, or they are simply very anxious. So the testing of cerebellar functions is very tedious and observation based in children. The standard medical tools like knee hammer, torch and tuning fork, they are used, but more in the older children. In the smaller children, it is the only tools are your eyes and your hands, which are used for observing the different activities of the children. And the very useful tools are the toys of the child himself or the nearby object like table and chairs, which are giving us lot of input about the child's cerebellar function. So how do we test the different domains? Like in the adults, we do the finger nose test. We in children can ask for reaching for suspended toys. We suspend a toy with thread and ask the patient to approach it. We can do the rebound test for trunk and tone by asking him to catch a ball and pulling away and throwing some resistance. Similarly, as we do the heel to shin in older children or adults, we can ask the child to show the coordination of the lower limb by kicking a ball or climbing onto a chair. And we can observe the child while running or walking in the hallway around a chair instead of a very formal tandem walking test as done in adults. So this is the old diagrammatic representation that how do we test the rebound test of the upper limb in a child. The normal response would be that the child would be, an arm would be coming back to the child for some distance, but in a child with cerebellar dysfunction, the arm may come to hit the child himself. So this mistake should be avoided, that we should place our hand so that the injury does not take place. So finger to nose testing for testing the coordination of the movement in a cooperative older child, we can do it like we do in the standard test for the adults. But in small children, we can suspend a toy and we can ask the child to approach the toy and see how the child's limbs are behaving. They are overshooting or there is a tremor at the end of the movement. So this is how we do the coordination test of overshooting or intention tremor. So sometimes the things get very tricky and child is more interested in toys than you yourself or the examiner. So we can test the child's observation of toys. We can test how the child approaches the toys or reaches out to the toys or nearby objects, and we can observe the intention tremor or the fast pointing in these activities. Similarly, in an older child, we can do the heel to shin test in a normal way as we do in the adults. But it is very difficult to command this situation to a small child. So instead, we ask the child to kick a ball, and we can see how the kicking movement takes place and how difficult for the child is to kick the ball every time. So this requires a period of observation. Similarly, we can place a toy on the chair or a small table and ask the child and see the child how the child approaches to get that toy. So in these small age groups, we can use the coordination in the lower extremities by this method. So ataxia during walking is tested by observing the child in the hallway, or how stable the child is while going around in chairs in near the patient bed. We can play the game of moving around the chair with the child and observe how the child is moving about in his path around the chair. And we should always remember 2-3 things whenever we are testing the cerebellar testing, particularly the gait. We remember now that by 1 year the child starts walking, but this is a broad-based gait. So this should not be taken as a sign of cerebellar dysfunction at this age. But if the same thing is found at 5 years of age, this is indicative of possible cerebellar dysfunction. And cerebellar function testing is also affected by the factors like spasticity, rigidity, dystonias. So we should be very careful while interpreting our findings of cerebellar testing. A good mnemonic about cerebellar testing is Danish: dysdiacokinesia, ataxia, nystagmus, intention tremor, slurred speech, and hypotonia. So in children, it is difficult, small children, it is very difficult to do dysdiacokinesia. We can ask the child, a small child, to tap the katori by spoon repeatedly. Or ataxia we can see when the child is moving around the table or chair. Nystagmus is observed by shining the light across the eye. It should be done last of all. And through the approach of the child to the toys, to the hanging toys or moving toys, we can test the intention tremor. We can test for the reflexes in an older child, and slurred speech can also be observed when we start talking to the child or when a child phonates by himself. So common pitfalls during the examination are when we are testing the finger to nose test correlate by testing the patient to approach the toy. We should not be moving the target too fast. This confuses the child and makes him uncooperative. So second pitfall is to ignore the motor weakness. For example, spasticity or a weak proximal muscle like in Gower, in Duchenne's muscular dystrophy. So these children can be having abnormal findings because of abnormal power in the muscles. And a child who sways with eyes open has cerebellar ataxia. A child who only sways when eyes are closed has only sensory ataxia. So Romberg test is used to differentiate between the two. This is an important diagnostic test in older children, and particularly with vitamin B12 deficiency or other dorsal tract lesions. So this is the common mistake that is done by the students, so we should avoid it. So we have to see all the three things. How is the trunk stability in the child, how we can do the rebound testing, what is the gait of the child, what is the finger nose test or heel knee shin test, we can do the modification in each of the areas according to the age of the child. And this is possible in many of the cases to assess the cerebellar function in many of the children, even the smaller age groups. So to summarize, before approaching the child, have a look at their history, have a look at the child's posture, behavior, and then we should try to observe the patient's spontaneous movement or the activities of the child. And cerebellar function testing is a mixture of observing as well as playing with the child, and in older children we can do the formal testing. And by testing all the three areas like trunk stability, the gait, and the hand-eye coordination, limb coordination, we can test all the areas of the cerebellar function. And last, I am again emphasizing on this thing that we should not interpret the cerebellar dysfunction in a child who has spasticity in all the limbs or in one side of the body, or he has weakness because of muscle dystrophy. And also we should see the child's ability to move the body limbs and do the activities according to the age of the child. So that is very, very important, and examiners are very interested in the student who takes into account all these factors. So guys, thank you for watching this video, and we shall meet you again in another topic on the pediatric neurology series. Thank you for watching.